So in terms of the video and also in terms of you guys, I'm going to start by finishing the supply of healthcare. And then whatever time is left, I'll start with gender and family. With gender and family, and that will be basically probably what I'll have time to cover today is really the end of Ben's lecture. So that's a bit of a hosh-posh, mixed mishmash lecture today, but this is... So where we left it last time is the idea that it's difficult for people to learn about health. Last time we discussed the fact that self-limiting diseases are a problem, and therefore that people also don't understand why a particular drug or compound treats them or doesn't treat them. In the lecture before that, we talked about externalities that makes it even harder to understand the impact of any drug that has externality on other, which is most drugs that have something to do with infectious diseases. And the consequence of all that is that indeed the private healthcare, as Arrow intuited, could be of a very, very, very bad quality. Just to give you a sense of how bad it is, so in India, Jishnu Das and a group of people did a survey in several states, which we are going to use a lot today, and they found that 77 of private providers in rural areas have no medical degree whatsoever. 18% of them have some other degree than a medical degree. 18% have a medical degree, but that's not like your regular med school, which is MBBS in India, the equivalent of an MD. The rest have this BAMS, BIMS, BOOMS, BHMS, which are some kind of alternative medicine or things like that. In the average village, there are 3.3 providers with no degree, less than one with some degree, and only 20% of the village have even one MBBS doctors. There are public providers who are more qualified and offer free services, but they have only 20% of the market share, up to 25% in villages where the primary health center is exactly located. Another thing is these private doctors that have 80% of the market share know very little. And to establish that, they used vignette, which I'll describe in a moment. And they do even less. So there is what's called in the medical literature a no-do gap, which is the gap between what you know and what you do. So how do we know what doctors know? So the way to do this that was pioneered by Jishnu Das and his group of colleagues is to use vignettes, very similar to what get administered in board exams. If you have friends who took board exams for medicine, you are presented with some information about a patient. The doctor is told that the patient will follow instruction, and they are given the standard tests. And then you're supposed as a doctor to ask questions, and then you're graded on whether you ask the right questions. And then you're given an answer, and you ask further questions. You come up with a diagnosis at the end. So you're also graded, of course, whether you got to the right diagnosis. So here a woman, for example, a woman comes to the clinic with a child who has had diarrhea for the last 2 days. So the doctor must first ask about their stool, not stock, to figure out if she has dysentery rather than a virus, and check for sign of dehydration. In this particular vignette, it is not a bacterial, it is a virus. There is no need for antibiotic. The right treatment is oral rehydration solution. So they use that vignette. They've been used, so Das, Hammer, and Ken Leonard have pioneered the use of the vignettes and used them in a number of settings. They have an overview of their work in their Journal of Economics Perspective from a few years ago. So what they do then is they use item response theory to code the answers to the question to create an index of competence, which solve for the optimal weights to each question. So basically, you weight less the question that everybody gets right anyway. You get more the questions that are more weighted. So this is something, a technique that's coming from education. So for example, when you take the GRE, your GRE are then graded according to item response theory, and then that's what is used to form your percentile ranks. and as opposed to just the raw score. So that's what they do here. So they create this index of competence. And so here people are graded by competence. And you can see that if we rank people by competence, then we can start asking questions. You can then ask descriptive question for people ranked by competence. So it's saying, for example, that among the most competent doctors, for the diarrhea question, only 50% of them asked about the stools, whether there was blood or mucus in the stool, which would have helped them to determine if there is dysentery. And among the least competent, basically none of them, a few percentage points even asked the question. So that's an example. In some countries, doctors are better. So for example, in Indonesia, they ask, and it depends on the thing. So for the check the fontanelle for dehydration, in India, like no one asked that question. In Tanzania, they ask it more often. Whether there was fever is a question that asked enough. The frequency of the stool is a question that asked more. For tuberculosis, do they ask the right questions? A fraction of the doctors that ask the right question in vignette. For the good doctors, it's very high. For anybody else, it's very low. That's for Indonesia. And I forgot to print what the question was. Question A, question B, was whether it was asked or not. So there is a lot of variation, but the overall quality is very low. So what they say is that the doctor has to be more than median quality, not to harm the patient with what they are doing. So if you remember the oath that the doctor take at the beginning of their career of do no harm, that doesn't, it's really not the case. In India, when you compare where people rank in terms of performance, from the vignette point of view, the top qualified doctors are better than the public doctors, but the public doctors are much better than the quacks, the ones who don't have a diploma. So you would expect people should come to the public doctor. When there is one available, it is both free and they are more competent. But yet they don't, and so why is that the case? And that's related to probably to what they do once you show up. So how to find out? So the first method that they did is just leave someone in the clinic for some time and do direct observation of patients as they come. So it has the issue that the doctors might adjust their behavior to the fact that they have someone observing them. That doesn't seem to be much of a problem from descriptive data I'm going to show you in a minute. Even with someone present to observe them, they spend about 2 minutes with the patient. So if they do even less when they don't have someone, then maybe it's even less. But even with that, they are. Even with someone observing them, they don't seem to be. Either their best behavior is truly terrible indeed, or they are not really on their best behavior. But there is another problem with this, which is that if you have someone sitting there observing the patient, that person doesn't know what the patient has, so they don't know what the right course of action would be. And in addition, good doctors might attract a different mix of patients. So when you're sitting there observing what is going on, you're also sitting there observing an endogenous response to an equilibrium where people have gone to that particular patient, and in ways that are essentially very, very difficult to control for. So to address these issues, all of these issues, potential of social desirability, not knowing what's the right course of action because you're not the doctor, you don't know the patient, and the potential endogenous sorting of patients that is hard to deal with, what they did is that they started sending a standardized patient. So that's the equivalent of an audit study. You might have seen this audit study in other fields, like, for example, to know whether car sales might discriminate against black people or against women. You can send a woman or a black person to the used car lot and try to and have them do negotiation and see whether They are given less time, they are given higher prices, or so on and so forth. So that's the idea of audit studies. Audit studies have been used in various settings, including the labor market. And so here the idea is to send a standardized patient to, who is afflicted by a particular ailment that they are the advantage to know. Of course, the disadvantage is that they don't actually have that ailment, but and goes and described his problems. So, doctor, I woke up this morning with crushing chest pain and was feeling very anxious. Then he answers the question, completes the basic exams. The provider recommends a treatment. So there are issues with that. Number one is, maybe it's not ethical to send a fake patient. So it's generally done in a context where you're telling them that they might be, you enrolling your doctors, tell them that they might be a standard patient at some point or another, which increases, or you reveal yourself at the end and you're asking, can I use the data from that? The detection rates are actually low, despite that, and provider behavior seems to be consistent with believing the standardized patient. And they don't seem to come to the conclusion that the standardized patient is faking it. I don't know why all of my inverted comma became question marks. But in fact, the more they do with the patient, the more they are convinced that the standardized patient is real. And they do even, for example, there is one case of standardized patient with his child diarrhea. Obviously, you cannot bring a child. So if someone comes to the doctor and says, there is a child in a village that has diarrhea, and then kind of answers to all the questions that are given to them. So did you check the blood? Did you check the stool to see if there was blood or mucus? They can give an answer to that, and so on and so forth. So the nice thing about this method, one of the nice things about this method is you can combine standardized patient vignettes. So you get direct information about the no-do gap. So you first send the standardized patient, then you go back to the doctor and say, hey, by the way, we had sent some standardized patient. Can we, are you okay for us to use this data? And if they are okay, they are given a vignette to answer So here are some data from the direct observation. Again, the doctors are classified by third of how much effort they exert between low effort, medium effort, high effort. So in India, in Delhi, they spend about 3.8 minutes with the patient. They ask 3 questions. They give 1 exam, and they give about 2.6, which we can round up to 3 medicines. So it's 3. 3 minutes, 3 questions, 3 medicines. It's easy to remember. In Paraguay, they spend a little bit more time. 8 minutes, they ask more questions, and they give fewer medicine. And you can see again that the effort is related to the time that is being spent. In Germany, people spend closer to Paraguay. In Belgium, they spend 15 minutes with the patient. But the number for India are particularly extreme in terms of how low the effort is. And then from the standardized patient, we can look at the type of treatment that is being given. So this is a standard patient, so you know what the correct treatment would be. You know what is the over-treatment. And you can see that in most, so this is various states in India and then China and Kenya. It's less than half the time, sometimes much less than half the time, that you get the correct treatment that the standardized patient get the correct treatment for what they presented with. Even in cases like, for example, one of their cases is a woman with preeclampsia. That's a pregnant woman who has essentially high blood pressure during pregnancy. It's a life-threatening condition. Even there, they don't get the correct treatment. So any correct treatment is the correct plus some more. Just the correct is even lower. A lot of people get over-treated, so they get medicine that they don't need for this particular case. incorrect treatment is current. For example, one example of over-treatment is antibiotic. So they think all the cases, none of these cases except possibly the standardized patient required antibiotic, and a lot of the cases got it anyways, 68% in Patna, 55 in Kenya, 35 in Madhya Pradesh got an antibiotic that they didn't need. The use of steroid is less popular, particularly outside of India, but you can see that in Bombay they are very popular. 20% of people who don't need steroid, the only indication for steroid here was the asthma case, go back with steroid. Referral is rare from this first-line doctor. You're hoping that they would refer, but referral are pretty rare. Another thing that you know from combining this vignette to the standardized payment is this evidence of this no-do gap. So you can use, if you use the same vignette, you can compare what they know to do because they are doing it on the vignette and what they actually do when the standardized patient is showing up at their doorstep. And you can see that there is always a no-do gap. These are all the steps. They do more of the right thing, and they are more likely to get any correct treatment on a vignette than on a standardized patient. And while the knowledge, as we saw before, increases with qualification, for example, the MD public, MD private untrained, the public guy knows more than the private guy. But what they know increases a lot with qualification. You can see it from private trained know the most, public trained knows a bit less, private untrained knows the least. But what they do, although there is the same U-shape pattern in this, that U-shape pattern is much flatter. So people are actually, the no-do gap increases with qualification. The no gap increases with qualification, but the no-do gap also increases. And in fact, in a lot of cases, at the end of the day, the public provider don't do much better than the private provider because although they know much more, they are even further from their frontier. So the no-do gap is a key thing to keep in mind. It's not just about training and knowledge, it's about incentive to actually do what is appropriate. Yep.
When are the vignettes administered? So are they administered during the course of the doctor's normal day? Because one potential explanation you could think of is, I know what the right answer is in a fully kind of like theoretical setup, but I'm dealing with many patients, I have a lot of demands on my time, and so I might just not be able to
attend to the thing. Yeah, it could be. If you spend 3 minutes, it's as much time as you have. So that could be, that's certainly with one of the parameters is how much effort you're giving to each patient and to each, to solving the problem that is in front of you. And the other, which we are going to spend a bit more time on, is also what are your incentives in terms of how you're going to get paid. So in particular, in a lot of settings, you're going to see an over-application of various kinds of medicine. And a lot of the payment model is that people are paid both for a fee for the visit, and then they're selling the medicine at the same time. So there is also an incentive that way and that's true of the private doctor and also of the public doctor who actually aren't paid a fee for the visit, but can sell medicine on the side. Yep.
You don't want to try to survey patients and see how they're willing to differentiate between qualifications of providers?
Yes, so the patients tend to know that the private provider are less qualified than the public provider. So that's the mystery of why they go anyways. And one of the resolution of that mystery might be there, which is although they are more qualified and they know more, they actually don't perform better in front of real patients.
Does trained mean they have like one of these several degrees? Or like, I guess, what is the vet? Like, do we know how MBBS doctors do versus, like, what is sort of the max?
That's MBBS. That's the best.
Or like, how do they do? Like, what is the max sort of do correctness?
Yeah, so in a sense, you have it here ranked by, so you would want to see we kind of have it here in the vignette. This is people ranked by performance, not ranked by MBBS, but ranked by performance. And you can see that, for example, it depends on the question. So so they are ranked by how good they are. And so the maximum for asking questions in the vignette is 45% for blood, and Fontanelle is very low. So what you want is a summary of of the correct treatment by ranking of standardized patient, or by how good do they get with the standardized patient. They have an answer to this question. That's in the paper. I don't have it on the top of my mind, but that's a good question. That's exactly what you do with this item response theory, is kind of trying to make them better, rank them by how good they are, and saying how good is the best doctor. And that's where they have sort of a summary of this. You need to be at least median to not hurt the patient. So most people choose the private sector despite that. Incorrect treatment cost the patient a lot of money. 70% of the cost of a visit in this study is the unnecessary treatment, the fact that they have to buy all these medicines they don't need. In Udaipur, where people are super, super poor, where we had done our health survey, 20% of the visits are to the public sector, which is free. 28% to the traditional healer, and the rest to the quacks. In Madhya Pradesh, 89% of visits are to a private doctor. 83%, even if there is a trained MBBS public doctor right in the village. So even with the MBBS public doctor, which is free in the village, people still go to a private doctor, including 77% to the unqualified private provider. And so there is a huge, so the idea of Arrow that the health sector should be mostly public because it's impossible to give quality. The first half is true, it's impossible to give quality, but the second is not true because most of the healthcare is delivered by private people. So why is that? So in Madhya Pradesh, they did this effort of standardized patient trained to represent the symptoms for 3 diseases. Those are the angina thing, like the heart attack, the asthma, and dysentery in a child who is not there. Then they went to, they have a sample of about 1,000 visits, and they have people who are moonlighting, public doctors who are moonlighting in the private sector, so they can put a fixed effect for a sample that is both public and private, and see whether they differ, they perform differently. And that gives some idea of how good why it happens. So it's true in Madhya Pradesh, like in the data I showed you, that the public sector doctors are more likely to be, or doctor providers are more likely to have an MBBS degree. This is a this is a sample of public MBBS provider. That's their fixed point sample. So of course, all of them have an MBBS. But in the sample as large, a quarter of the public and less than 10% of the private providers have a degree. They know a bit more. This is from the vignettes. They know a bit more. But they do even less. So this is the number of time they spent with a doctor. In the representative sample, they spent so this is a regression of private provider compared to public provider. They spend about 1.2 minutes, including case, market, district, fixed effect, 1.5 minutes more with the patient on a basis of a mean of 3.6 in the private. In the public, sorry. They complete more of the private doctor complete more of the checklist items. So even though they know more, even though they know less, they do more. And so their IRT score, how good is their total management of this case in terms of asking the question, is higher. Even though, again, they know they are less likely to be qualified and they know more. That's true in the sample at large, and that's true with very similar numbers, in fact, when you compare among MBBS doctors who are all in the public sector, their behavior in private and public. which reflect this mix of incentives, time spent, and so on. So that's a big underestimated of the difference in the service that someone can explain, because this is conditional of being found. And in a lot of cases, the doctor is not even there, or the public facility is closed. As a result, they don't treat any better. If we compare whether the public people give the correct diagnosis or not, well, the private doctors are more likely to give a diagnosis. And then conditional on diagnosis, they are no worse. The private are no worse. And then there is no difference at all when we compare the behavior in the fixed effect sample. So even though again so that would explain why the people go to them, there is one difference between them, which is it's that the private sector tend to over-medicate. The private doctors tend to give more medicine, about 1 more on average, on a mean of 3. Although that's not true in the dual practice sample. So they don't do worse. They give a bit more. They don't do better either. The private guys, they don't do worse, and they give a bit more. They give a bit more medicine. So that would explain why people might continue going to the private sector, despite the fact that the private sector is not very good. They are treated better. The doctor will spend a few more minutes with them, ask them a bit more questions. At the end of the day, they don't treat them in a worse way. I mean, the treatment is bad, but it's bad also in the public sector. And they give them some more medicine to buy, which is a waste from our point of view, but it's something that there is a demand for the reason we explained, that people feel good if they can do something against their ailment, even if the something in question is not really necessary. So that's where we are. So compared to the arrow situation where you shouldn't have a private sector, you should have public sectors, because that's the only way to get good quality medicine, we have awful quality, mostly delivered by the private sector, but whatever the public sector delivers is not much better. So what to do in front of this situation? So this is a place where, compared to education, where when I got to this point on the supply of education, I was able to share with you at least an idea of what's the main problem, what to do about it. I think this is a situation where in health, we haven't reached this point yet, where many things have been tried, which I'm going to briefly show you in each categories. But there is, I think, much less of a consensus that anything in particular is a good thing or a bad thing, or has been successful or not successful. So that makes it exciting for a research topic, especially post-COVID, where the health situation is, even more important and urgent and interesting. And therefore, it's worth spending some time on it. So what can we do? So option one, which was pushed by our colleague Larry Summers for some time, although I think he has somewhat moved on from that, is more of the same. Universal healthcare, worldwide universal healthcare. So basically, spend more budget, make sure that each country has more budget to spend on the public sector. That seems like a terrible idea. In the current situation where absenteeism in public health facility is 50%, even when you can get hold of someone, the treatment is there, it seems that pouring more money into the same system is unlikely to be super successful. I'm not going to spend much time on that, although that's, in a sense, the status quo proposal in the international world is we just need to spend more money. In fact, India did that. They went from spending about 2% of GDP on healthcare, on public healthcare, to spending 10% of GDP, with very little to show for it in terms of healthcare quality. So we'll move that aside. Then you could try to make the public sector better by improving their incentives. I'll show you 2 papers showing that this, it seems like difficult. We can try, but it's difficult. since this comes, so that's one class of question. Maybe you can do better than the papers I'm going to show you. Another class of solution is that you could say, well, since it's all come from the consumers. In fact, I had a discussion with one of you yesterday after, last week after presenting the Bjorkman and co paper on the medicine in Uganda. Is the solution seems to be to provide more information, to teach the people, what is good drug and bad drug and what a good drug should do. So basically, the idea is that since a lot of the root of the problem comes from the fact that people don't understand fully what makes you sick and what makes you heal and what to do about it, basically try to make them more sophisticated. I'll show you one example of that. And then the third is try to work with the private sector. However bad it is there, it is here, it is available. Try to make it better in some sense. So I'll give you an example in each of the three categories. There are studies in each of the three categories. So incentivize the public sector. So Abhijit, Rachel Glester, and me did the first attempt there. On the heel of a successful project I had done with Rima Hanna of giving incentives to teachers to show up more regularly to their classes, which had been quite effective. We gave incentive for payment for day of presence, and it worked. They came more. So we tried to do something similar in the same setting in Udaipur for nurses which were absent. And absenteeism rate was crazy high at the beginning. We had surveyed a health center for a year, once a week, and they were absent 70% of the time, and it was completely unpredictable when they were open. It's not that they were open every Monday, so you at least could come. It was just from time to time, a nurse showed up and opened the center. So we tried and changed that. So we did something which you would characterize as unambitious, which is we agreed with the government, something we did in collaboration with the government. The government told everyone in the place, treatment and control centers, you have to be open for sure 1 day a week on Monday. Now this is a new rule. You cannot go to the field on that day. You have to be in your center. You cannot go to functions. You cannot go to training. You have to be there. And then, so that was common for the treatment and control. And then what we did is that we put in place a system to monitor presence. This was before the time of easy fingerprint recognition, so we had to make up some system where they had to sign, stamp, and sign again something on the register to show that they were in fact present on that day. And then we sent a person to do some random checks. We controlled the absence both on Monday and on other days, although the incentive was only based on days. So what we find is that in treatment, initially, the absence rate really increased on Mondays and not as much on other days. So initially there was, by the way, there was a screw-up in this experiment, which is we didn't collect control data for some time. We started controlling control data after a few weeks. So this is the control group when we have both. The control group is indeed lower than the treatment group, particularly on Monday. Then over time, the treatment group is less and less and less and less and less there. In fact, the control group is more and more and more and more there. So that at the end of the experiment, about a year into the experiment, the control group is doing better on Monday and on other days than the treatment group. So this is not what I would call a successful experiment, where we actually managed to worsen absenteeism in our centers compared to the status quo situation. So what happened? So I'll tell you what happened in the control group. I think what happened in the control group is that they progressively learned. This idea that you have to be open on Monday was new. And the message was kind of progressively spreading. And so over time, the regular administration was putting some pressure on everyone to be there on Monday. They removed the training programs on Monday. They told them that emission days have to be on other days than Mondays. So all of that sort of made its way, and the control group improved. Fine. So that makes sense for why this should have improved. But why did this go down? Meanwhile, in the treatment group, it started quite high, and then it went down even on Mondays. In your opinion, what could have happened? Yeah.
They realized there wasn't consequences?
Exactly. So they realized there wasn't any consequences. How did that happen? Well, they started being present more, but they were still absent quite a bit. And then there were 3 categories. You were either a present day, an absent day, or an excused day. And over time, what happens is that the bosses of these nurses, which are the doctors in the PhDs, converted all of the absent day into excused days. And they made all sorts of excuses for them, including that they were training, even though we knew there were no training on those days. But still on the register, you had lists of excuses. You had to do this, you had to do that, etc. So that in fact, when you compare the official register, there's almost, at the beginning, there is absence. And then, and very few exam days. And then over time, there are no absences, and there are only exam days. So the exam days increase enormously, the absence go down, and that's why finally the treatment is worse than the control. So basically, they learn progressively that the rule is not enforced anyway, so there is no reason to bother. And the fact that the rule was very, very clear, which is you have your absence, the absence, if it's not excused, is going to take away from your salary, makes it even obvious that actually the rule is not enforced. So there is a rule, but it's not enforced, so we are good to go. Whereas in the control group, there is, it's the normal thing in the bureaucracy, which is there is always this vague threat of punishment that might hold upon you, and you have no data to confirm whether that vague threat of punishment is going to be carried out or not. Yeah.
Do you know what they do when they don't show up to the office?
What they do when they don't show up to the office, yeah, they're home. These nurses, they are well educated. They don't want to live in the middle of the village. They have kids that they send to school. So they live pretty far from their center. And to show up, they need to take a bus and all that. It's a hassle. So if you cannot show up, then why? Why not? And then, so that's basically what they are. They are home. They take care of their kids, etc. And once we had sent the clear message that going to office was not a requirement of the job, then that makes it even more obvious. Yeah.
You said that the control group doesn't have any data to know that they actually don't enforce it at the moment, but wouldn't they just realize that they've been missing Mondays all this whole time and nothing has happened?
Well, it's not as clear, because the punishment, the normal punishment in the absence of daily incentive is you might get sacked at some point. So they still have their supervisor that tell them if you don't show up on Monday, you might be sacked and all that. And so that's probably somewhere in the back of their mind. Whereas here there is a pretty clear rule, which is if you don't show up on Mondays, you're going to get pay deducted. And then you can see that your pay is never deducted because the absence is very regular. Here, in the control group, they don't know. Nobody is measuring their absence, but there are these irregular visits by supervisor. They don't know when the supervisor might show up. So that's the kind of disadvantage of having a clear rule that is not enforced, make it is easier to you understand what the incentives are. So I think this is what happened here. But then the next question is like, how could the government get away with not implementing their own rules? And one of the possible reasons is no one cares because everybody has anyway abandoned on they're giving up on the centers and they're not putting, it's not something that is very high. Improving the quality of the center is not something that's very high on everybody's priority. And this is shown by the fact that it didn't bring back clients. So at the beginning of the experiment, when the facilities were open more often, you could see whether more clients came. In a given day when we did these visits, you see one person, not even all the time. 0.74 clients in treatment facility when it's open, 0.81 clients in private facilities. So people don't care. Basically, they have given up. And that's why we call the paper putting a Band-Aid on the corpse. Because basically the system, without any demand for that system in the first place, there is no, it doesn't really rise up, bubble up to the level of priorities. Yeah.
I'm assuming we know that the relatives nearby the facilities knew of this new rule and they knew it would be open and they still didn't show up, or do we know that?
Well, so the rule was put on the centers, but you have to have some minimal level of credibility that actually it's going to be enforced, which nobody had any trust. If you watch on YouTube, there is Abhijit's movie on the healthcare in Udaipur called The Name of the Disease. And there is a very funny sequence where we interview someone about a girl about the center, and she's like, she first gives all sorts of excuses to them, and then finally she said, well, she's never there anyways. So there is a pretty good understanding that that's the status quo. And you're right, people, there is a chicken and egg problem. The nurses are saying there's no point for me coming. Nobody comes anywhere. It's totally depressing to sit in my DRAP center with no medicine and no patients. And the patient said, why would I even go there when I can go to any of 10 private guy who is unqualified but not so much worse and at least is available. So reforming from the top without building a demand seems to be difficult. So that's that. So hence there is the other idea of building a demand, maybe starting from a system which is less defunct in the first place, which it is in most countries in Africa. The centers are open, there is more life there. So there is a very nice paper by the same Björkman and Svensson of the medicine. That's actually an earlier paper. Similar problems. The absence rate in the health center is 47%. I think it's not as bad in the sense that they are not defunct, and the centers are a bit larger. So there is kind of always somewhere, but a lot of them are absent. The care is not great. So instead of using the top-down approach that we tried, they involved the community in monitoring the provider. So this was, at the time, this has slightly gone out of fashion, but about 10 years ago, 15 years ago in the World Bank, this was everything. There was a public service, a World Bank annual report on public service delivery, which was all about, power to the people, empowering the people, etc., community empowerment. And this is one of the few attempts to really take this idea seriously to the field and test it. So what they did is that they first went and collected a household survey with experience with people health facilities. Then they hired community-based organizations to facilitate 3 meetings, a community meeting, a meeting at the health center, and an interface meeting involving both the nurses and the doctor and the people. They had to come up with an action plan about how to improve the situation and how the community member would come and do monitoring on the facilities, which is a bit worrisome from the, like the Texas law of vigilantes coming to the facilities to monitor them, but it's probably not that sinister. So people, kind of encourage, volunteer to come and monitor that the nurses were there and so on and so forth. The results were pretty great. This is impressive results. Absenteeism went down from 47 to 34%. People did come more, either as a result of absenteeism or perhaps declining, or perhaps because, unlike in our case, there was this public meeting, so everybody knew it was supposed to be better. They still continue to use the traditional healer, but on balance, which is the key litmus test of this intervention being effective, the under 5 mortality rate went from 144 per 1,000 to 94 per 1,000. Even more remarkably, the same team did a follow-up maybe 10 years later in the same facilities, and they still see impact. So I really believe that this intervention worked in this set of villages. That said, it is not really a replicable intervention. It is extraordinarily expensive to conduct all of this meeting. It has to be done just so. Any attempt to replicate it in other contexts has not worked. Not because this one was, not. I don't think this one was a fluke, but it's just because this one was particularly well done. Nobody has managed to do it as well. So there is, for example, a replication study by political scientists, I think also in Uganda, trying to do just the same and not finding any effect. So they have a bit of a dispute with them where they're saying they didn't do just the same, it wasn't quite as good. But the point is that that's just such an intense intervention that it's hard to replicate. So what Björkman Svensson did is that they tried a lighter version of this intervention where they give the information to people on the facilities, but they don't have all of the community meeting. Actually, now I have a doubt whether which element they got rid of, whether it was the full survey or the community meeting. But anyway, some lighter version that they were hopeful would work out, and then it didn't work. They have no impact on it at all. So their own effort, which has to be commended, of realizing that that's a super nice proof of concept, but if you want to scale it up, it has to be a little bit more manageable. The effort to make this more manageable have not worked out. So it's a nice proof of concept, probably not the way that you would, it's not ready for prime time in terms of this is what we're going to scale up to improve the situation. So that's for our reforming the public sector by providing incentive, either top-down or bottom-up. Second class of things, could you just make the consumer more sophisticated? Teach them exactly how things work and see. So one example of that is a paper by Jessica Cohen, Pascaline Dupin, and Simon Shanner, where they basically create sophistication by introducing a rapid diagnosis test for malaria that wasn't there before. So people can understand. One of the people, this is in Kenya, where there is routine overtreatment for malaria. In particular, people take this ACT, the new drug, even when they don't have malaria. So they're trying to test that. But the first thing they do, as just background, so the ACT is this new artemisinin combination therapy. It's effective today. The older anti-malaria medicine is not effective in Kenya anymore. And if this one is used too much, it's also going to become ineffective. This might all be solved if everybody gets vaccinated against malaria, but at the time, there was no vaccines for malaria. So what they did is first replicating the study on subsidizing treatment. And so I've showed you a graph where we subsidize preventive care showing high elasticity. And here you're finding that when you move from no subsidy to complete subsidy, there is actually people are more likely to take ACT when they have some subsidy. They are more likely to take any, and they're more likely to use their voucher. But the impact is much less big. You go from full subsidy to 80% subsidy, you get a 15 percentage point increase in take-up. So there is an elasticity. It's not as brutal as for preventive care. But the problem is that it leads to the people that it convinced to take. We have the same issue as what was discussed for preventive care. The people who get convinced to take the ACT anyways are the people who don't have malaria. So basically, people are able to predict relatively well whether or not they actually have malaria. And the people who think they have malaria, who think quite strongly they have malaria, take the pill regardless of the subsidy. But the people who don't, wait to see. So we can look at this predicted positivity is based on what the patient could know about them. Their fever, shivering, various kind of symptoms. Are they predicted to be positive? And this is compared to the 92% subsidy. So compared to the 92% subsidy, when the subsidy is lower, people are more likely to be predicted positive for malaria when they take the medicine. So in other words, making it near free encourages a lot of people who think they don't have malaria to do it anyways, to take the drug anyways. And in fact, when you test them, so what they do is that they go to the facility, people who come and say, can I give you a test now? And they also find that compared to the 20%, 92% subsidy, compared to nearly full subsidy, people who had to pay more are more likely to, in fact, be positive for malaria. So here you find, in the case of this curative care, you have this effect of the extra subsidy drawing in a lot of people who don't really need it, which we didn't find in the case of preventive care. So that's point one. This is a detour because what I want to talk to you is about testing. So their question is that, well, we are in this world where people basically over-medicate for malaria. Only, on average, only 50% of people, 56% of people who test for malaria and have taken an SCT have malaria. That means 44% of people take an SCT when they shouldn't, when it's not required. So they say, well, if we tested people for malaria, then maybe they wouldn't need to take the medicine if they didn't have it, and we would have fewer. So what they offer is, and the problem is that, and that's the source of the lack of sophistication here, is not the patient's fault, is the fact that the fact that there exists no good tests. And the test that is proposed in the public health center has very high error rate of both type 1 and type 2, so they are kind of not very discriminant, and therefore, and people know that. So here what they do is that they buy a bunch of rapid diagnostic tests, which are much better, and can be administered at the pharmacy. So it's basically thinking of getting your COVID test, antigenic COVID test, you get the response in 15 minutes, then only you take the medicine once the Merck medicine will be approved. So here, same thing, but for malaria. And what they find is that a lot of people are perfectly willing to try with the test. 20% of people, if they have to pay for it, and it goes to on average about 50% if it's subsidized. And if they have a higher predicted malaria, then they're more likely to take the test. So people seem to be happy to try. The problem is that they don't listen to the results. So if the test is positive, everyone takes the drug. So that's good in that direction. If the test is positive, everyone takes the drug. But if the test is negative, the compliance is not taking ACT, and you can see that even with the lowest subsidy level, 80%, half the people do not take the medicine, half the people do, despite the fact that they just learn right this second that they don't have malaria. And if you subsidize them, then only 25% of them abstain to take the malaria medicine, so 75% of them take the medicine, even though the test just told them that they don't have malaria. And it's not that they take the medicine and hide it. It's they take it and take it. So what's going on here? So that's the first problem. The second problem is that it doesn't really help with targeting. Even after the RDT, the extra people who are drawn in to take the medicine, despite the fact that they just tested negative, are mostly the people who don't have malaria. So it doesn't really help with your mistargeting. So what happened? What happened is that even this new shiny test is not trusted and probably because the standard test has a lot of errors. And so people don't know if this one is really much better, it's new, and so they were happy to do it, but they prefer to rely on their intuition anyways. And this shows how difficult it is, how the mistrust make it difficult to introduce a new device that will help people to do better. And in fact, I was talking to a graduate student in Michigan a few weeks ago who is doing a project on Nigeria, where they have made a huge effort to improve the supply chain for malaria medications. And now they're pretty sure that the malaria medication they have everywhere is of good quality, but people do not believe it. And they are trying to figure out how to increase the trust in the quality of the malaria medicine in a setting where nobody trusts it in the first place. So that's the difficulty with making. That's an example of, I think, partially successful attempt, but not fully successful attempt of making consumer more sophisticated. I'm not saying this shows this is not a path, but it shows that there is more work to be done. Maybe a conjunction with a supply chain effort, maybe maybe you need to work at larger scale. I don't know. This remains quite open. Last one is working with a private health provider. So this is a project that was which was done by Abhijit, Jishnu Das, Reshma Husam, who was a student here at the time, and Abhijit Chowdhury, who is a doctor in West Bengal. And what they did is that, so it was mainly, Abhijit Chowdhury is a very well-known liver specialist, but on the side of that, he has an NGO that provides healthcare to people in Birbhum and a hospital there. And what these people did, they're called the Liver Foundation, is that they set up together a training program for the healthcare, for the private doctor, saying, look, they are going to be there anyways. People trust them. People go to them. They have a smaller nodal gap than the public doctors. Can we just try to train them both to recognize what they cannot deal with and triage, and deal with a number of the medicine. This is something that the medical profession absolutely hate. The idea that you would, in some sense, train and therefore legitimate those the quacks, and so to speak, is something that is very, very, very unpopular with the regular medical profession. But I tried anyways. The main outcomes were quality of care as measured by the same 3 standardized patients as I showed you for Madhya Pradesh. And what do they find? This is the result as presented in Science. They published in Science, so we have a nice compact presentation of results. So first of all, the training was free, but it was very demanding. It was over several weeks, etc. They went through a lot of cases. And it was a bit long, so people had to take half a day of work away. So the attendance was only 56% on average. At the end of the day, they got nothing. They didn't even get a certificate because the medical profession hate the idea of certificates. So they just got, they could tell their patient have been trained, but they didn't have something to prove it. And so 56% of people showed up, and on average, they train better in the treatment group than in the control group, bridging about half the gap with the public sector. And those who managed to go all the way till the end improved more. This is not experimental anymore. Unfortunately, the training had no impact on the avoidance of unnecessary antibiotic. So what happened is that they performed, they identified better what the client has. They were more likely to provide correct treatment. But on top of that, they throw in some antibiotic as well to round up the bill. So two extra things to say what happened. What is interesting is that when you look at what they know, just from the vignette, they don't seem to know much more in treatment and in control, despite the fact that they've just been trained. But what happened is that they performed, they do more. Like, so they've basically, the treatment helps bridge the no-do gap. They do more of what they know. And so they, in the treatment guys, complete more item in the checklist. And what you see here is that, so this is your correct treatment as a function of the number of checklist items you complete. And basically, the more items you complete in the checklist, the more you are likely to end up on the correct treatment. That's for the standardized patient. And that function didn't really change much in the treatment versus the control group. So it's not that they were, they changed their production function. It's just that the treatment moved this density to the right. So they were a bit, they just, did put a bit more either effort or just knowing this is what I have to do for this particular patient. Not knowing, but like actually doing it. So basically the treatment reinforced for them the importance of actually doing what they were supposed to do. It didn't change their propensity to treat with medication, and that is almost surely because they are paid by a function of the number of medication they give, and therefore this would have been inexpensive. It would have been a too expensive proposition to not throw in a few expensive propositions. So to sum up, the private sector does provide low standard of care, the public sector as well. And on top of that, the public sector provides poor service, which is why people prefer the private sector. So shutting down completely the unqualified private sector is the option that in a lot of cases, that's what the medical profession pushes, which is not realistic, not consistent with the number of doctors you can train in a particular year, and not consistent with the fact that doctors do not want to go in rural places. And therefore, unless you force them to go there, usually after medical college in most developing countries, you need to go for a year. But you would need to force people to go like for 10 years. And nobody is very interested in that regulation. So what to do then? So mostly, there is lack of training in the private sector. We've seen that, but mostly people don't even do what they know. And part of the problem is people don't necessarily trust them. They are skeptical of their advice. They know that they are not well trained. They suspect them to be corrupt. So they stay within their capacity as much as possible. So some certification and other help in building a reputation for being a good guy might help. Some checklists. So I don't know if you've seen there is a book called Checklist or something like that, which is actually from a doctor. The book is not just about doctor, but it started with applying checklists in hospital. So even in the US, introducing checklists increases the quality of care a lot. You would think that for a lot of these cases, like a tool to build a checklist would help. I don't know if people have tried that. And then, not tying the revenue model with selling antibiotic would be good. And forcing some regulation might work well. For not the regulation saying you cannot exercise, which is not possible, but you have to get a test, and then on this vignette, and then you can get a certificate which you can show on your window, so that would increase their training and their regulation. Requiring them to attend training on basic patient safety to limit the damage they can make, like for example, not sharing needles, sterilization, CPR, and the like, and involve them in public health campaign. Because they are connected to the patient. So in fact, during the COVID crisis, there was an effort in West Bengal and maybe in other places as well, but in West Bengal there was an effort to include the unqualified local provider as first, screening and first response to help people deal with COVID during the several waves that India had. What it did, I don't know. I haven't seen a study yet, but there was actually one effort along these lines. So that's what I had to say on the supply of healthcare. I'm happy to take questions, and then otherwise I can sort of move on and complete what Ben didn't get to in his lecture. So, yeah.
Could you say a little more about the medical college thing? Like in the U.S., there's like the restriction of doctors by AMA or whatever is like we think of, like what is sort of the situation in terms of access to medical education?
Yeah, so like in the US, it's very restrictive. In the countries I know, it's very restricted and very competitive. So this is true in East Africa, this is true in Ghana, this is true in India. Partly for the same reason, which is the doctors are, have this way of enforcing their own rarity. Partly also because it's hard to train doctors. Unlike, training teachers, primary school teachers, that is relatively, it's actually very hard to train doctors. And to train doctors, you also need doctors who are willing to train other doctors and taking some time off of being a doctor, where and presumably good doctors where they are both needed where they are and they could make a lot of money. So that's basically a bind. So there is this kind of inherent limit in not just because of the putting a cap numerus clausus that you find in rich countries. France has the same thing, but also because of the technology of producing doctors who are highly qualified people who therefore have a lot of other possibilities. Very much like we discussed for the case of secondary school teacher, but even worse. Incidentally, this is something that it has a parallel in the US with the training of nurses. where despite the fact that there is a shortage of nurses, there is a huge excess supply in the number of people who would like to be nurse, to apply for nursing degrees, who can't get to nursing schools. And one of the reasons why they can't get in nursing school is that there is nobody to teach them to be a nurse, because the nurses who are in exercise are required to actually be nurses. And they can make much, much more money trying to be nurses or trying to be teachers. So they need to be a reform of the teaching sectors for nurses in the US. And I think it's a little bit similar. There is the extra problem in India that all the nurses that are trained are then absorbed in the US because it's one sector where, at least pre-COVID, I don't know if they've liberalized, but being an immigrating to be a nurse was always very easy in the US. That puts one more set of pressure on the supply of qualified nurses in developing countries. And also on the outside option, you were asking, what do the nurses do? Well, you know, if the people who are managing them perfectly know that their outside option is leaving and going somewhere else. And there is also, in this way, that's the reason why nurses are treated well. In India or in Uganda or elsewhere, putting too much pressure on them they would just pack up and go to the US and make money. Great. So that's the end of the health lecture. I'm saying that to the camera. I'm going to now move to talk about gender and the famine. And I just looked at what Ben had time to cover, and I figured what would make sense is to I made my own slides, but cover some of the papers that were at the end of his slides, and that he didn't have time to get to. So, and that's kind of that's a very natural segue into talking about gender issues, which I'm gonna do then finish on Monday. So you finished last time the lecture on talking about Chris Udry's paper, which is a classic among the classic, showing that there is no efficiency in production. One more thing we could ask is whether there is efficiency in consumption. If households were able to insure each other with full commitment, that is, they are able to, if we had an efficient household model, efficiency requires that conditional on total household demand for eating, who gets what and what goods are being consumed and by whom should be invariant of the actual realization, because you know you're here for the long time. So if I'm doing, even if I like potatoes and you like beef, the consumption of potato and beef should remain relatively constant, because it's not because I earn a bit more money this period. Next time it's going to be you, and we should kind of be able to insure each other for this change. So the consumption of a particular commodity shouldn't depend on a shock that affects one person versus the other. In other words, the shocks should affect the consumption of each individual goods only to the extent that they affect total consumption. So the household might not be able to insure its entire set of consumption. That, in turn, is going to have implication what they consume. For example, if they feel very poor, at some point they might eat mostly potatoes because they don't have money for beef. But that should only transit from, that should not be over and above the impact of total consumption on the demand for the various kind of goods. So the consumption of the wife should not drop because of a particular bad draw, and similarly for the husband, because they can insure each other later. So of course you'll do much more of insurance in the spring semester, so it'll become clear that it is correct, but the intuition doesn't require that much. So are household members able to insure each other against transitory shock? And the answer to that is no. So first, I want to go through an experimental paper It's a paper by John Robinson. In fact, it was his job market paper when he was in a Princeton graduate student. And it was a graduate student paper, so it was not very big, but he had 142 married couple and followed them for 8 weeks in Kenya. And each week he met them, and each individual in the couple had a 50% chance of receiving 150 shilling, equivalent to roughly a 1.5 days income for men and 1 week income for women. So something, not irrelevant. So people received their payment. Then both spouses knew what they had. And then what they did is that he got diary data, very similar, that they did for their savings paper with Pascaline. In fact, same type of people doing, cycle rickshaw or women selling on markets and stuff like that. This type of very regular work. Did these diaries, and then he collected data on income and income shocks and labor supply from each member. So the shocks are like textbook shock. They are random, they are transitory, because every day there is a new lottery, and they are idiosyncratic. They should not affect the bargaining power of each person. They are also public, so there should not be, there's no incentive to lie, it is not possible anyways. There is no moral hazard, there is no labor supply. So you would expect complete sharing if the household was consumption efficient. And surprisingly, you don't, which is people who get more money, they spend more. So when men get more money, also when a respondent gets more money, these are the men. If it's the respondent who gets more money, they consume more on private good, and nothing else really. So they consume nothing else really changed. So when they have money, when they get 1 shilling more, they spend about 0.19 shilling in total, and all on private consumption. And for women, they don't do so much. So private consumption is like newspaper, snacks, bottles, sodas, that kind of things. So women don't do that, but they buy themselves a lot of medical expenses, medical stuff. And you might wonder, well, but they just got 1 shilling. What happened to the rest? And the rest is saved, which makes a lot of sense. But it is not saved by. It's not saved by in a public way for the household. It's saved in. So you can see that it's saved total, but it's saved mostly in private. I'm looking for the private. No, it's saved mostly in private vehicles. So they don't save in the form of. Their bank account, etc. They save basically each under their own mattress. So when people get a shock, men save about 0.8 of it, and the rest is they spend on themselves. Women save less of it. The rest is spent a little bit more spread across things. In fact, they do buy some more food. They buy medical expenses, a little bit on the kids. So that's sort of not consistent with and the men spend nothing of when the spouse get more money, they get nothing. They don't transfer the money to the spouse. At least women transfer a bit of their money to the spouse. Men don't. But on the other hand, if their spouse gives them money, they receive money, they give them lower transfers. So women and men behave a little bit differently, with women doing more of the shared things. But both of them basically save the majority of the money under their own private mattress, which is not what would be expected given the households, efficient household model. So we already saw that they were not efficient in production. They are not efficient in consumption. So this is an experiment. That's a small experiment. Chris Udry and I have a paper famously unpublished. I can tell you one day what happened to that paper and why it's still a working paper. Maybe one day we'll publish it. It's in Côte d'Ivoire. It's the first paper I wrote after graduating. Well, started with a completely brand new paper I wrote after graduating. So to tell you it's old. And it uses the fact that women and men tend to grow different crops on their different farms. So you already seen that in the Udry paper that they grow on different farms, but on top of that they grow different crop. So there are women crop, men crop, and then yams. So yams are male crops, but they have to be used for feeding people, either by being directly eaten or by being sold to buy food. And there is a very, very strong social norm in this direction. So in Côte d'Ivoire, we know what people produce. And so you can compute proxies for male. You don't know what every individual produces, but you know what the household produces and how much money they make from their different crops. So you can compute proxies for male income, female income, and yam income by aggregating crop income across the different crops, knowing that probably the way that it's done in practice is different from the. So this Côte d'Ivoire survey is a panel. In fact, it's an overlapping panel. There are 3 years of it, but people appear either in year 1 and 2 or in year 2 and 3. So for each household, we stack the two. So for each household, we see them twice. We look at the change in their income from 1 year to the next. And then we predict. So this is done in an OLS. It's done in a two-stage least square, but imagine, for the sake of pedagogy, that we use predicted income. So we predict for each person how much better they are doing in year 2 compared to year 1, the difference in year 2 income to year 1 income for female income, male income, and yam income. And we run a regression of the change in consumption on the predicted female income, male income, and yam income. So the question is, in a Pareto efficient model, would we expect any difference between beta, gamma, and delta, potentially? So we look at consumption of various goods. So we're going to look at food, private expenditure, public expenditure. Well, I would normally wait, but it's 11:55, so you're saved by the bell. You would, because they might have different time paths. So, for example, if a lot of the male income is coffee, and the fact that you get good income today is probably a good prediction that you're gonna get good income tomorrow, because that means your trees are doing well. And if the women are producing vegetables, this is perennial, there's maybe less information in. So we know that from the savings group that people should save transitory income and consume permanent income. So to the extent that there is different income process for these 3 groups, we might expect a different effect on consumption, on total consumption, and therefore we might expect different impact on individual good consumption. So what this suggests is that the consumption of any particular good should change, but only to the extent that total expenditure change. So you want to run the same regression with total expenditure as the dependent variable, and then calculate this ratio, and basically they should be equal. It's kind of and I'm sure there isn't much. Should we now decide to publish this paper, instead we would do GMM or some fancy thing like that, which would come to that, which is basically saying, well, you know, if female income has a coefficient on total consumption that is larger than male income, then it should also have a consumption of a larger effect on everything else, but that's it. So all these ratios should be the same. And they're not, is the conclusion. They're not at all. So the male income, yam income, female income is spent in entirely different ways, and in ways that is that is consistent with the income are being sent to there, the various streams of income are being kept separate and being sent on various, on their various purpose. I'll just show you one slide. So these are all of the coefficients themselves. Total expenditure. Female income is slightly more responsibility to female income than to non-YAM and to YAM income. That's just what it is. But then if you're looking at the various goods, for example, the goods that are prestige goods, so these are stuff that people buy for themselves, like ceremonial clothes and that kind of things, are being spent, not at the YAM income has no impact on that. It's each individual income. Female and males both spend a lot of, have a large propensity to spend out of female income. Now, if you look at the YAM income, it's being spent on staple more than anything else, which makes you might think it makes sense. It's because they just eat the yam they have there. But it is also spent on stuff that's not a staple, but that's common goods, and in particular, education. So people spend their YAM income on education and on staple. They spend their private income on prestige good. Women spend a lot of their income on food. Of course, they grow vegetables, so maybe that's related to the farm gate to market difference. But they also buy meat. They buy processed food. And in general, the purchased food only responds to the female income and not to the male income. So that's consistent with it is the job of the woman to put food on the table. So when their income goes up, food goes up. And there is no, the male income is not being channeled to this. So that's another example in real life, non-experimental real life example of the failure to do household optimization. And therefore, it doesn't seem to be that it's an efficient household model. So where does that leave us? And that's why I wanted to finish that today. That if leaves us to, well, clearly the efficient household model is not a very good model of the family. So a lot of the modern literature on the family and on gender economics is about trying to understand what is going on, whether families are in any way different than a random collection of individuals that just met a minute ago. And if so, in what way, and what are the barriers that stand between a household and efficiency, information, trust, social norms, and so on and so forth. So that's what I'll do on Monday, and with an emphasis on women labor supply, which is a big policy area in its own right. Thank you.